Hi there, and welcome to the While You Wait podcast. We work to bring you stories of humanity, care, and hope from across the Arkansas healthcare landscape, all while you wait to start your day. Our series is hosted by the staff of the Arkansas Behavioral Health Integration Network, a local nonprofit dedicated to better health for all through integration. This morning, we have project manager Caitlin Johnson and peer specialist Megan Copeland as your host. On today's episode, we explore the topic of postpartum and maternal mental health. We are grateful for the chance to talk to Dr. Chad Rodgers as he shares his perspectives and experiences. We will get to that in just a moment, but we are a new podcast, so please remember to subscribe and share wherever you get your podcast. Also, feel free to drop us a note at www.abhinetwork.org for any feedback, questions, or episode suggestions. With that housekeeping done, let's get started with the episode. Today's topic is about postpartum and maternal mental health. I think everyone can attest to the physical and mental loads mothers carry and how they can affect their mental health and well-being, but care for this specific population can be hard to access. There could be stigma associated with seeking help as a mother, time constraints, or even a lack of education awareness that postpartum is not supposed to be like this.
You know, if you think about how motherhood is portrayed in the media, it kind of perpetuates some of this thought, maybe the stigma or the awareness that postpartum isn't really supposed to be like that. If you're aware of pop culture references, you know, the Goldbergs is an example, or Malcolm in the Middle, if we're looking at the early 2000s, or a show even like Roseanne, where the mother was really the foundation of the family. They did everything. They ran everything, gave medicine out. Yeah, they did the laundry. I mean, they kept everyone alive. So it wouldn't be surprising to me if some of this was just because there's not enough education to those who are new mothers, on how life is supposed to look after you have a child.
So the expectations may not be on the mother physically because they're healing from childbirth, but think about intellectually how much they're put under strain with questions like, where are the diapers? How many scoops of formula do I need to put into this bottle?
Mm-hmm.
Or even, what's our kid's teacher's name?
Mm-hmm. Right. So including the mental load that mothers deal with, we also know that about 75% of mothers with an already diagnosed mental health need don't receive the care for it throughout their pregnancy or even immediately after. And again, you know, Megan, you said that could be due to several things, but once it's left untreated, it could be fatal. And from the CDC, they released some key findings last year that 23% of pregnancy-related deaths are related to mental health, like suicide or substance abuse or substance overdose. So, and you're going to hear us say that term throughout the podcast episode, pregnancy-related death. And we wanted to give you a definition of that. And that is a death of a woman while pregnant or within 1 year of the end of a pregnancy, regardless of the outcome, duration, or site of the pregnancy. And it's from any cause related to or aggravated by the pregnancy or its management, but it's not accidental or incidental causes. It's a long definition, but we wanted to make sure that we said that before we went through the whole podcast episode.
Absolutely. You know, pregnancy can be a motivator for many pregnant women that are struggling with SUD to significantly reduce and or even abstain from substances. However, the hormonal cascade and stress of childbirth and infant care can create a significant risk of relapse in the postpartum period. It can actually up to triple increase in risk of overdose mortality in the postpartum period. Late postpartum and fentanyl are actually the highest risk areas.
Mm-hmm. Mm-hmm. And we know that's such a big problem right now in Arkansas fentanyl is in everything.
And, you know, thinking about this, not to even mention the mothers that return to use after a pregnancy and they think they can go back to using the same amounts they were using before.
Right.
And then that accidental overdose.
Right.
And death.
Yeah. Right. So, I mean, this is pretty overwhelming, kind of a daunting task to tackle, even as a clinician and even as a peer who's worked in this space for a while, talking about mental health and substance use it can be overwhelming even for us clinicians. So thinking back over the statistics we just went over and considering how we can address this health crisis, we wanted to make sure we steered our listeners in the right direction. So we invited 2 Arkansas-based providers to join us on today's episode, and they're going to let us pick the reins and explain how they combat this mental health crisis in their own practice and how listeners can implement these interventions into their own clinics as well.
So we're here today with Dr. Chad Rodgers, who is a pediatrician. Chad, can you introduce yourself to us?
Sure. I'm Chad Rodgers. I'm a pediatrician here in Little Rock. So I'm a pediatric by training, so I'm a doctor for kids. I've been doing it for about 25 years, but I also work for a healthcare quality company called Arkansas Foundation for Medical Care, or we often just refer to as AFMC, which actually started as a medical review company, but over the last 50 years, we have grown into doing a lot of provider relations for people who are on Medicaid, they give services that benefit Medicaid recipients and also beneficiaries, but also health education. And so a whole lot of things. So I have a lot of overlap, and it's not public health, but it's sort of the promotion of public health in a lot of ways. But I kind of did private practice for about 15, 16 years and was doing a lot of child advocacy and a lot of healthcare advocacy, and just needed a way to kind of blend both of those worlds. I had been on the board for AFMC, and they were looking for a chief medical officer. And so I applied at that time and left the board and took that position. And it's kind of allowed me to do my child advocacy, my health advocacy, and get paid for it, which is kind of nice. Because before then, I was having to take time out of practice in order to do these things to kind of help children and families. And it's allows me the time and the effort and the resources to do that. So it's been good. It's been a good career.
Amazing. Very cool. So can you tell me where you're from and some hobbies that you have?
Sure. So I was born and raised here in Little Rock, and then I went away to the country of Texas for 4 short years. And I came back to Arkansas to go to medical school and then train at Arkansas Children's Hospital. And so I made my career, my life here. And I live here in the city of Little Rock with my husband. We have a stepdaughter and 2 grandchildren. So we like to spend a lot of time with those. That's become a major hobby. If you could have child advocacy as a hobby, I guess that's been my hobby. We were kind of joking about my schedule and all the things I do, but I really do enjoy doing those things and being a part of, like the Arkansas Medical Society and the state chapter of the American Academy of Pediatrics. And so it sounds like a lot of meetings, and it is, but it's a lot of being with people. But when I do take off, I really enjoy travel. And I love the arts. I love music, and I do some pottery. I actually have been on a little 10-year hiatus from my pottery career, but I'm starting back next week
Cool.
and getting back to throwing on the wheel. So I'm trying to find some balance in my life here at this point in my life.
Fun. I'll have to take a chapter out of your book on how to mesh life and work together and make it a hobby. I love it. So what motivated you to get into this field?
Well, as far as maternal health goes, I didn't really think that that's what I was going into. My dad was a family practitioner, and so family practice docs sort of do it all. When I got into medical school, that was sort of the road I was going down, was family medicine. And then I got into my very last rotation of my junior year of medical school in pediatrics, and I just fell in love with the career pediatrics. So a little change of course there in the last couple of weeks. Timing wise, it was kind of interesting, but I really wanted to go into pediatrics because of preventive health, really trying to help promote healthy interventions for people as they're growing up so that they grow up into a healthy adults. So that was for the goal. My background, actually, in college, I was a fitness instructor and did a lot of personal training and a lot of nutrition consulting. And so it kind of fit well with this prevention aspect. So I go into pediatrics. When you train at children's, you train to take care of very sick children.
Mm-hmm.
And they do an excellent job doing that. But I wanted to be in that role of the general pediatrician. So you get very involved in people's life. You meet people when a very exciting time in their life, when they're starting their family or have had a baby. It's also the most terrifying time of their life.
Absolutely.
Yeah, having just gone through it, you sort of know. So it's a really great part of being the pediatrics. I mean, I definitely was like a pediatrician to friends. But then a lot of the families that I met them because they had a baby and they started coming to me. And so even though I didn't go into family practice, I take care of the whole family because it just became real evident to me within the first 5, 6, 7 years of practice that you can't take care of babies and you can't help children unless you're really taking it. I'm going to say take care of mama. I try to take care of the whole family, but my relationship with the mothers, it's very close, and it's a great role to be involved with that. So in order to have healthy kids, we got to have healthy moms. I mean, that's just sort of the bottom line. I think the other thing that has come more apparent to me in the last 10 years is that I take care of these young women, these 13, 14, 15, 16-year-olds who are your next moms, and they're really not that far away. We think that there's like this gradual transformation into adulthood, and it's really a very short journey. And especially for a lot of our young women in Arkansas, because people do kind of tend to marry early. They tend to have babies earlier. We have a high rate of accidental pregnancy or unintended pregnancy. And so you have a teenage girl that goes to being a mom really quickly. And then all of a sudden we have these expectations of them that they're that they have all the skills that they need in order to be a parent or a mother. And we don't. I mean, I had great parents, and I didn't realize the skills I was lacking until I became a parent.
Absolutely. You've already blown my mind because as a young mom myself, I had my first child at 16, and like this whole idea of the mom being treated along with the child as the pediatrician is just like,
yeah.
I'm blown.
It's kind of funny too. My partners and I were talking about the other day, like when we're training as residents, we're in our 20s, and so a lot of us haven't started our families yet. And when we were training, we're kind of a little bit judgy sometimes of the parents because you're like, how did your kid fall out of that window?
Yeah.
And then you like grow up and then you have your own children and then you're talking to a family and they're like, well, he fell out of the window. And you're like, well, I can see how that.
Yeah. That's how that happens.
So there's a journey for us too. But it is real obvious to me that I couldn't help improve child health if we didn't do the work to help improve things for moms and for dads and for families in general. So it became my hobby, the passion. So
you just gained yourself a new patient. I'm gonna. I know.
That's the hard part. I work 2 days a week. As I still get to be involved, and I get to do the part that I want, but the continuum is not that good. But I have really wonderful, wonderful partners so that
great
even take care of my family. So yeah.
What made you so passionate about early childhood trauma and the whole family approach?
Right. I think I had been practicing for about 15 years, and because of the families that I worked with, I was intuitively aware that there were much greater things going on with the families I saw. I mean, I think we already knew that 80% of what happens in people's health occurs outside of the exam room, outside of the hospital. But I don't think we had a true appreciation for what exactly was it and how was it happening and what was sort of the measured impact on families. So when I came across, actually, I got started down the path of social determinants of health, which sort of involves things that are non-medical, like housing, education, food insecurity, the things that impact people's ability to be healthy. Because I'd actually, if you back that up even more, I had gotten interested in health literacy before that, people's ability to take health care information and use it to make decisions. So that got more to the social determinants of health. And then ACEs, or adverse childhood experiences, just kept bubbling up. And so nobody really knew ACEs. I mean, I think we felt them, and we kind of had an idea that it's not good when a child's been abused, right? We know that impact. But I don't think even then, or even until recently, that we even realized the relational impact that has on child development and on mental health. So, as I began to kind of look more, and, the ACEs study, the original ACEs study was done in Southern California back in the 90s. It was between the CDC and Kaiser Permanente, where they looked at adults and they looked at experiences that they had in their childhood, called these adverse childhood experiences. And they sort of studied 10. There's obviously a lot more than 10. That can impact, but they wanted to see what those things that happened and occurred in childhood, how they would affect adults. And so there's a score of 0 to 10, if you had one experience or 10, and they are actually pretty common experiences that a lot of people have had. But the higher ACEs score, the more likely you were to have significant health or mental health problems.
Right.
And so that really began to kind of give you this measurement of the impact. And when it occurred, we know how important those first 5 years of life are when the child is developing the brain. And I think there was this sort of misconception for a lot of people that children don't remember what happened at 2, or they can't comprehend or understand at age 5. So, certain traumatic things they just thought didn't impact children. But now we really have the language and the science and the data to show how that impacts brain development on down the road. So even when you're in your 20s and 30s and your 50s and your 60s and your 80s, even how those early childhood experiences shaped your life and shaped your health and shaped your mental health and the choices you made along the way. And so it was like a light bulb for me in my practice. And there were a lot of families that I worked with where I would get super frustrated because, you almost feel like these people don't care about their kids. They're not showing up for appointments. The mom got back on drugs. The dad is never here. They can't seem to get it together and get out of their housing situation. We made these referrals and they did. So you're like, what's the deal? And then all of a sudden this light bulb comes on and you realize how much trauma impacts people and those experiences and your decision-making abilities, sort of your experience in life and how you react to life. Because these folks are really in survival mode.
Yep.
They're really trying to do the best they can to stay alive and keep their kids alive. Parents really, I think that's the great role of pediatricians. They really are looking to you to kind of help them. Because they kind of see you as a child, at an expert in child health and well-being. And so they're looking to you for answers to questions and that aren't readily available because their parents didn't teach them to them and they can't teach them to their kids.
Absolutely.
And so you kind of walk in with this whole skill set and they're just being very reactionary. They don't have time to think about the big picture of things. They're just trying to respond to the fact that their child is having a tantrum.
Yep. Or
they're trying to get away from a spouse in an abusive relationship, or they don't have a family network to reach out to because of a parent is in prison, or a parent has a drug addiction, or they're a substance use disorder, or, there's so many things. And you just see the complexity and you can get totally overwhelmed with it, like how we can talk about it right now. And then you realize that there are things you can do about it. There are little things, and just having some compassion and many for us being very empathetic, because many of these things have happened to us as well, to kind of help carry them through that process. So I using that ACEs study, and it doesn't really matter to what your ACEs score is to me, as much as it is for me to recognize that this is occurring to people, this is happening to people, this is impacting their health. And I don't have to know specifically what happened to them, but just that recognition that something is going on, I think it makes me more helpful, and it changes the way that I approach people. And I think it has helped me a lot with burnout, personally and professionally.
Just give you a shift in thinking.
Yeah, a little shift in thinking. And so that's what they talk about when you do ACEs work, that you shift from this whole was like, what's wrong with you, to begin thinking about, well, what happened to you? Yeah. And it really is such a light bulb moment. And it really did transform everything to me from, early childhood, talking about, that book sharing and talking to your child, to what to do when your teenager begins to use drugs, or what to do to help mom if she's having, some substance abuse issues, or she's having some domestic issues with an intimate partner, all those things. And so it's been really transformative to my practice and my approach and my advocacy too.
It's hard to think about how you get all that done in one exam appointment,
Right.
like, 1 20-minute, 30-minute appointment, depending on what they're coming in for. And it just speaks to how much medicine is not, obviously you're treating diagnoses and ailments, but how much of it's just helping somebody navigate through normal life occurrences.
Yeah.
So just kudos to you for getting all that done in 20-minute appointments and relying on your team and other avenues. So
full disclosure, that is the kind of the joy of primary care is, even though healthcare is set up to be pretty episodic, it's very continuous. And so, that's the great thing about pediatric care too, is when you see people, especially the first 2 years of life, you're seeing them very frequently, every couple of weeks, to every couple of years. And so that relationship builds, and it's a real trusted, and people, will tell you things. But there are a lot of things, if you don't ask, they won't bring it up, and because it's very normal to them. And if you don't ask or you don't screen them for something, you may never know and definitely could miss something. So.
That is so true, because I was just talking to Caitlin about that earlier. Many times, like anytime that I went to see my pediatrician, I would never be concentrated on what's going on with me. It's always what's going on with my child. And even if something was going on with me, I'm going to put on my big girl britches and make sure that I'm holding face while I'm there and can get out of there and then fall apart, you know?
Yeah. I'm not cracking on dads, but I'm telling you that, dads come in and they have a hangnail and they're just like, call an ambulance and we're calling. Y'all come in and I'll see kids sometimes, and I'll tell you the mom is 10 times sicker than the child. And so after I get done seeing the kid, I'm like, well, how are you? Because you need to be at home. And then that women are just amazing in that concept of what they're able to rise up and above. I mean, they can have the flu, but still, take care of the family. Dads do as well, but I guess it's just something innate to women that they're so strong.
That resonates deeply. They didn't.
You're thinking when you're a teenager, I would never do that.
Yeah.
Become a parent, and all of a sudden you're like wiping poop and wiping nose.
Yeah. In situations you never would imagine you would be able to handle.
So people may be a little surprised to hear from a pediatrician on an episode that's focusing on maternal mental health, but we know that you sit on the Arkansas Maternal Mortality Review Committee. Mm-hmm. Would you give us a little bit of insight on what that committee does for the state and what your role is on that committee?
Right. So Arkansas passed some legislation several years ago to begin to look at maternal deaths in Arkansas. So anything that occurred 1 year after birth. To look at what happened in the course of that pregnancy and after that postpartum period up to a full year that may have contributed or may have been part of that mother dying. Unfortunately, what we don't capture is all the other stuff that happens. But of course, the mortality is the biggest thing that we want to prevent for these moms. So other states do this, and we take the data and they pull out the information from the charts. It's all like, we don't know either the mom's name or anything like that. It's all de-identified. We don't even know really what part of the state. We do get some characteristics of the part of the state that they're in, because it kind of helps us think about what can we do in the medical care system to improve these outcomes for these moms to prevent death. And out of that process, we looked well over 30 cases, maybe close to 40 over the last 2 or 3 years, to see what those are and what the common elements are. And it's very systematic. And then that data is actually reported to a national center where they can use that to kind of look how we compare nationally. But it really helps us look, again, at what can we do as far as where the mom delivers, where she went for care, where she could have gotten somewhere faster. But we also look at the things around the mom. So where she lived, what the social supports were. So there's a variety of factors. And then at the end, we try to make some recommendations to the state, to the legislative committee that oversees this, to what could be done to improve things in Arkansas. So it's sort of interesting because there's a lot of physicians on the board. So I come from the pediatrician, but there's family practice doctors, there's OB-GYNs, there's a cardiologist, there's an anesthesiologist who does deliveries. So, but there's all social workers, and there's nurses and people with different aspects. But it's interesting because there are a lot of things that we could do within the healthcare system, but there's a lot of things that again occur outside the healthcare system. And how do we address those issues? And so those are the ones that can actually sometimes become a little overwhelming to the committee when we're trying to kind of look at things. But I think, looking through the lens of adverse childhood experiences and what we call trauma-informed decision-making and some other things, we're able to come up with some good recommendations every year. And we're beginning to kind of see that get some momentum. We have a couple of years worth of data and a couple of years worth of recommendations. And, there is fortunately a really strong interest in improving women's health overall, but particularly in the area of maternal health. So,
how often do you guys meet?
We meet quarterly. and we meet for a whole day. And I will tell you, it is like a marathon.
It's heavy stuff that you guys are discussing.
Yeah, it's very heavy. Sometimes we have to take breaks, and we have to kind of process, because you are talking about people's lives, and sometimes it can be very weighty. And a lot of times they're just really tragic stories, but it's we go through each one. We have this incredible team of people who work at the health department who go through and they collect information from the emergency room and from family practice offices and from the delivery itself, and any kind of social information that they could pull from the chart about who they're married to or what insurance they have. Because these things all help us kind of make those determinations. So, I mean, you really do get a pretty good picture of the situation, but each case takes about an hour.
Wow.
Sometimes more, sometimes a little less. Sometimes it's very obvious up front. I guess from the medical perspective, sometimes it's easier when it's a medical issue, because we're like, oh, we should have had, a pack on the floor in a hospital that could have helped the mother with bleeding or helped with the delivery or something like that. Other times it's just really complex, difficult situation. And I think the thing that overwhelms us all are those sort of things that are pregnancy associated, but not particularly related. And we can talk about that more. But, it's things like suicide and substance abuse and overdose. And those it gets very weighty. Yeah.
Okay, so let's talk a little bit now about how does a pediatrician concentrate on and treat postpartum mental health?
Yeah, so, thinking about that relationship between mothers and babies, which it's the most important relationship, I think, in your life. I mean, we all remember, that whole connection between your mom. And so we know that if mom is not in good health and if she's not in good mental health, that's going to have significant impact on the child's mental health, but also on their development and then just on kind of basic needs. So again, it's like to take care of the baby, kind of having to take care of the mother as well. The other thing is, a lot of times after, we were just talking a little while ago about, how moms show up to the visit, they're sick and they're not feeling well. It's the same thing in that postpartum period. A lot of times it's the time in which they come to the doctor and they're coming to the doctor for the baby, but not for themselves. Mm-hmm. And because life is busy or because they lack transportation or maybe they lost their coverage, they're not following up with other, physicians, they are bringing their baby to the doctor. And so it's a real opportunity to intervene. And again, I think a lot of times they're kind of looking to us for a trusted resource. So necessarily phenomenon, it just happens. But like now that I'm 20 years into practice, a lot of the people who are mothers were patients of mine,
Oh, yeah.
So there's a lot of continuity there. So I think that, it's of all the things that we can kind of help mothers with is sort of helping to identify when they are having some difficulty, because they are so focused on their children and on their baby those first couple of weeks and months. So it becomes a good point of intervention to kind of get with mom and ask them where they are, ask them if they followed up with their OB, making sure they have the things that they need for nutrition and those sort of things. So it's a really good, important role for the pediatrician and anyone who provides pediatric care. So nurse practitioners, family doctors, most of our kids in the state are taking care outside of pediatric offices. So I have to remember our colleagues that are seeing, and they play and for a family practice, they take care of the whole family. So even better,
Yeah.
Yeah.
And that kind of leads me into, is it the mother's responsibility to step up and say when they're having problems, and how do you identify that there's that need?
Yeah, I think there's two things when I think about this. One is sometimes I don't think we're real aware that we're struggling. I mean, I think like you just had a baby, so you're fatigued and maybe you feel down and,
blame it on the normal.
Yeah, that's just what everybody goes through after their pregnancy. And I think they get kind of told that, sometimes, oh, you just had a baby, you need to rest and all that kind of stuff. And so the second part of that is that I don't think that moms sometimes know what to ask. And so I think that's where screening becomes so important. And that's one of the great things that the state is now paying for is for depression screening right after moms delivers in the hospital, but also in their follow-up visits into the pediatrics offices. So that moms are getting asked those questions. And, I think it's important. Sometimes surprisingly, people don't know that that we are a resource. Like,
Yeah, I had no clue.
Yeah.
I had no clue. Yeah.
I was so excited to introduce her to you. I was like, you're going to love him. He's got so much information.
You're like, this is not the right space for me to tell this. And
Right.
and they're like, oh, you care about that too,
Yeah.
And so
me coming from a substance use background, I was obviously paranoid and afraid that people would want to take my child if I went in and had issues and explained my issues. So knowing that that stigma is a little bit broken at this point, that people are more educated and more aware of how to deal with things is very promising.
Yeah, very promising. And I think that's just like with ACEs. I think there's a whole shift in that. I mean, I think the goal is to keep that baby with its mother if the baby can be saved. But if the mom is a lot of times given the resources or the treatments that she needs in order to be a healthier person.
It is the lack of resources in many cases.
Easily.
Because I'm from rural Arkansas and there just wasn't anything there. There was no treatment. There was no peer support back then, any of that. So,
oh my gosh. Yeah. My family is from Southeast Arkansas. My dad's extended family, but I grew up in Little Rock and then I practiced in Little Rock. But I also worked on, the Arkansas Medical Society and then the Arkansas. And I think about my context of living in Central Arkansas and all the resources. And then I find myself complaining and I think, what do people in Lake Village do? What do people, in Helena do? It becomes a real different approach. And so, yeah, it's what goes on in rural Arkansas, where most people are.
Yeah,
it's really different from Central Arkansas.
Do you have any specific cases that you could give us where you have done an intervention and it has changed the outcome for a family?
Yeah, I mean, I think sometimes I probably will minimize them, and because sometimes people don't come back until later to thank you. I think we started doing maternal depression screening before the state really paid for it because we just thought it was really important. It was a recommendation of the American Academy of Pediatrics, and so it's not a real complex screening to do, but it was just picking up on those things. The fact that you asked about it, occasionally the mom is like, I've been asked this 3 times now, I'm fine.
Right.
And that's good. If that moms are that's the moms that we do pick up. And I think that there's so many times that moms just kind of feel heard and not kind of brushed away or pushed away. And so I hear those stories a lot from moms. Like they're like, I was really in the depths of postpartum and I couldn't think, I could barely take a shower. And the fact that we sort of took that time to intervene is really important. I mean, I think the main thing is, they want to be listened to. It's a very isolating time for moms too, because we're kind of stay at home and recover and stay away from germs. If they don't have good family support or good spousal or partner support, it's really isolating. And during the pandemic, it got really bad. Because there was like nowhere to go or to reach out to.
Absolutely.
We kind of lost a lot of our traditional social structures that kind of catch people and help support them. And so I could think of tons of stories where people came back and just said, thank you for asking the question.
That's why you do the work.
Yeah, exactly. And so it's pretty rewarding. And like you always remember the really bad cases.
Yeah.
And you always forget the times that things went well. And it's always nice when somebody comes up to me and says, thank you for doing that. And sometimes it's like, oh, that was just part of my day, but how impactful that is for people.
Well, I haven't had that experience with my pediatrician, but I just want to say thank you from the outside for doing this work, because I'm sure that many moms are very thankful for the work that you're doing.
Thank you.
So I'm curious, when you do identify somebody, maybe through the screener or just asking them, are you okay? You may need some help. What do you do with those patients? How do you provide the intervention and how do you get them help?
Yeah. So again, recognizing be the first step. A lot of times, because they are especially in that immediate postpartum period, they are following up with their OB-GYN. So referring them back to the doctor if they need, medications. In the worst case scenario is if they are feeling suicidal or thinking about harming themselves or their children, getting kind of interventions in place very immediately. I mean, that's like a medical emergency for that mom.
Right.
So referring to them, what unfortunately has been the hard part is there is, this element of postpartum depression, but sometimes there's not, there's just depression and there's just anxiety that is already kind of part of the picture. And so getting those moms beyond just getting them on Zoloft or Prozac, it can be frustrating because there's not always a good, like there's not a therapist that can be there tomorrow. Now there are growing a number of interventions is what's been shown to be very helpful, and what we have been part of as a Healthy Steps to do a Pritzker's grant, where we actually have a social worker in the office, and we really call them our Healthy Step specialists, because they're not going to be doing a lot of counseling, but they help when we identify somebody. They come into the room, they introduce themselves, they give them some resources, but they also kind of follow up with them and make sure that they got to who we talked about, or they're going for the visits, or they're going to back to their OB-GYN. And it's also a person for them, the mom, to reach out to. And it's within our office. So they're not bothering the doctor, but they're talking to somebody who we have entrusted to sort of do that intervention. And that has been really helpful. Again, really transformative to the practice. It's really gotten more popular across the country. And so hopefully we're kind of looking at that now in the state of Arkansas. Hopefully that will be something that continues to grow because it's really good. But a lot of times, just calling in some extra family support, our close friends, if you had, a doula or a midwife, those are really great resources, or, the nurse practitioner you're seeing, but trying to kind of up those resources. Home visiting is another really great intervention. So I think sometimes at home visiting too, because they can walk into the picture and see what's going on. And again, I think families sometimes fear the home visiting nurse, like they're going to come in and they're going to take their baby away because there's, some food on the floor, and you're ready to it's like, hey, you just need to pick food up. Let me do that for you while you do that. But it's a good place for them to see and touch base. And again, kind of a trusted source to talk about interventions you could do with your baby, to promote good development, but also, are you taking care of yourself? Have you seen your doctor? Right. Are you feeling depressed? So I think there's, and it gets to the, kind of the moral of the story is like, there needs to be multiple points of intervention, not just one. Good point. Oh, we did that. Yep. She's fine. Because sometimes, and I'm talking to you because you've got kids, but, you may be fine 1 week or one day and you're not fine.
You're not. Yeah.
So I think the multiple points of intervention are where we can identify and help and refer and treat. But we still really need a lot more resources. And I don't think it has to be like for a lot of things, I don't think it has to be like a medically trained PhD person. It can be another mom who has gone through an experience. Yep. I mean, I think, moms and grandmothers, if they're available, or a good resource, sometimes they give unsolicited advice. But again, I think having kind of surrounding and supporting that mom with some things, and it could be someone in the community that has had a baby, that has been through it and has had that experience. I think speak more to a mom than even what I do,
Right. Just like with peer support, someone that's walked through it before, you can relate with them so much better. And I love what you're saying about the multiple checkpoints, because one day I may be going in and feeling like, oh, I've got this. I'm not going to say anything. And the next day,
I washed my hair today.
Yeah. That'd be really good. Absolutely.
Yeah.
And you may need people for different weeks, right? You may need somebody like mom 1 week, and then you may need medical help the next week, and you may just need your neighbor down the street to help cook dinner, one night a week, whatever.
Yeah, someone to watch the baby for an hour, go take a shower.
Yeah, exactly. So we don't have all the answers, right? Not one person, not one clinician has all the answers. So being open, and I'm really encouraged to hear that your team and you are open to different disciplines and anyone who can help. He answered one of my questions, so I had to. Okay, let me see where.
Well, but I do think, this from your substance abuse treatment world, like when people are in crisis, when they feel alone. And I mean, that's the story you'll hear again and again and again. Nobody asked, nobody called. And I think that those little things are so important to helping people stay connected.
Yep.
Because people think we're more connected now than we've ever been with social media, but it's not the same as that human connection, so.
This may be kind of off the record with this podcast, but when I was 16 and I had my youngest daughter, and I was on drugs, not during the pregnancy. Well, I smoked weed at the beginning of the pregnancy, but I was on meth after the pregnancy. And whenever DHS was called in to intervene on the situation, it was just like the ball was dropped. They they took Ryan out of the home, which was what was best for her. But they didn't give me any options of, I didn't know what rehab was at that point. I didn't know that, and there was no rehab in small town Arkansas. I didn't know anything about really the steps to try to get her back. I just knew that I failed the drug test and they were taking my kid away. So it's just like that helpless feeling.
When you were 16.
You were out anyway, right? Yeah. And I didn't have my mother in my life. So it was like, I didn't have anywhere to turn, and I just continued to use, and it just continued to spiral out of control for many years after that.
Yeah. And I think, and then when we reviewed it, we see that story over and over and over again. And the impact that the opioid and meth and even marijuana use has had on the state. And I think there's a lot of discussion and a lot of thought and a lot of change of thought around, when the moms will seek treatment. And what you don't want when a mom has gotten pregnant and they are on a substance, it's for them just to do it on their own, because then they could put their own health at risk. They put the baby at risk. We don't know when the baby's delivered or the mom's in the hospital, that could put the baby particularly at risk, in those first couple of days of life. So we really got to change our thinking. And that so many moms are motivated to get treatment because of their children. And so I think that's a real time to kind of seize on that opportunity and kind of
the vulnerability allows that, yes.
And stop making them feel like they're bad kids or they're bad moms. Right. They really need some help and some treatment. We just like if you've got, diabetes or anything else. And so I think identifying those resources, sometimes we just don't have enough. But that approach is much better than taking someone's baby away. Yeah. I think that's pretty cruel to do.
Well, then it's just generational at that point. If that child grows up and then they have been through trauma themselves at that point, it's just, unproductive.
It just perpetuates the cycle.
Yep.
So I think that there's always a time in the visit with any family where, you certainly have, when you go in as a provider, you have your agenda. How's the baby feeding? How's the baby sleeping? There always has to be that opportunity for what are you worried about or what are your concerns? And letting people not feel like you're in a hurry. And it's also not check a box. But I think that that's where screening becomes so important because a lot of times we can't quite put into words what we're feeling. So a lot of times, or we're embarrassed to admit what we're feeling. And knowing that creates sort of a safe place to talk about it. And I think that traditionally, especially maybe, I don't know, I grew up in the South, so I think it's Southerners, we don't like to ask about those things, And I think that we have to kind of get over that. There's always, especially with like youth, people are terrified to talk about suicide because they think they're going to go out and commit suicide.
Right.
And we know that they're less likely to. Just like the people are kind of afraid to talk about sex because if we talk about sex, they're going to go have sex. Well, it actually shows that they're less likely. And if they do, they're going to be more prepared.
Yep.
So we have to kind of get over these taboos with an exam room. And I think that's also, and we talk a lot about in trauma-informed care about creating safe spaces for families. If you had felt safe with your provider, would you might have gone earlier in the pregnancy, you might have talked to them about your substance abuse use disorder, and then maybe the story could have been totally different, right? In the end, things turned out fine, but still, I think you still kind of carry that trauma with you with time. But we got to kind of not be afraid to ask those questions. And I think sometimes healthcare providers are afraid to ask questions that they don't have solutions to.
Exactly.
And so if I asked if mom's depressed, then what am I going to do?
If she says yes, we're not here.
So you got to know how you're going to respond to that question. Although I think sometimes it's okay. Well, I don't know either, but we're going to find something.
Absolutely. Care has to ask.
Yeah. So I think that would really kind of help change the conversation a lot. I think making information readily available in the office. I talked about social media earlier, but I think it's a really good place to kind of normalize, some of the postpartum depression, or if you're struggling, that there's other people going through that as well.
I think some of our listeners may be really excited to hear that some of these screeners are being paid for.
Mm-hmm.
So just to clarify, can pediatric offices submit claims for these maternal depression screenings?
We can.
Okay.
And so there's a lot of things that we can screen for, and sometimes it becomes part of the visit. But when you look at, when I know we talked about trauma and trauma screening earlier, but screening for maternal depression is screening for an adverse childhood experience, an ACE.
Okay.
So it's so important. And sometimes you can kind of piece that together, a little bit. But they are getting more commonly done. Some of our screens for, I started earlier about, they also take care of teenagers in a matter of a couple of weeks, they can become a mom. So using screens with adolescents for substance use, but also for depression. I think I have been shocked since we started screening how many people, I'm like, you tested positive, are you screening positive for depression and anxiety? And they're like, well, isn't everybody depression and anxious? They never thought that this was the place where they could get information or where they could talk about that.
Right. Yeah.
So I think as we move along, we see how important those screens are and kind of bring up the conversation. And if the answer is, no, then you can concentrate on a whole lot of other things than just, those. So,
yeah, I think that's great for sustainability for a lot of like smaller offices that are having to maximize as much of the day as they can, knowing that that just sounds like it makes it more accessible for a lot of patients to be able to be reimbursed for that and to catch people who would typically fall through the cracks.
Yeah.
Right? So doing a kind of population health approach, like you talked about earlier, the conversation of a blanket screener is a good practice to have.
Yeah. And I think with the screens, using a screening tool too, so we try to send them out before sometimes they have it done in a visit, or sometimes just that 15 minutes between, hopefully it's only 15 minutes between the lobby and the exam room. They've looked at it and they think, well, maybe I am depressed, so a lot of times they're not even thinking about it. So they'll kind of process those things, or they begin thinking about it in the time. And so that they bring it up. They may, screen it, but they're like, well, you asked me about this, and
right.
I am having, some problems with my partner or my husband, my spouse, so.
Gives them some confidence to talk to you about it.
It gives a safe place to talk about.
Yeah. So I know we briefly talked about suicide and overdoses. So I kind of wanted to get a little bit more specific to Arkansas. The CDC recently indicated that about 23% of all pregnancy-related deaths are caused by mental health conditions nationally. How do you see this compared to what is going on in Arkansas?
Yeah, well, we know that in Arkansas that it's much higher. I mean, it's much higher overall for substance use disorders and for opioid use, but in pregnant women and especially for overdoses. And some of all the cases where we look back, I mean, some days, like we had an entire day full of cases that were all just related to overdose.
Wow.
And so it is very impactful and it's so preventable. I talked about in this really high tech, things that we keep in the emergency room or labor delivery floor systems to prevent death of women. And when we were just talking about having Narcan in the home,
right,
can save somebody's life, or helping them get to treatment. So it's much higher in Arkansas. Unfortunately, I think the tide has been sort of hard to slow down. I mean, hopefully we're kind of seeing, I think we kind of peaked with like the highest ever prescriptions. Maybe those are beginning to come down as prescribers have gotten more knowledgeable, as people have become more aware of the impact of those. And then, having fentanyl strips available, I think it's generally a good intervention. They were considered like drug paraphernalia, illegal to have. Mm-hmm. And yet it's such a cheap, life-saving, easy thing. And if you think about some of the exposure with like marijuana and some of the things like that, how important it is.
Fentanyl is in every drug.
Thing. Yeah.
So it's, we just have a lot of room to grow, and a lot of that includes, our culture change, but also increasingly, amount of resources we have for people to get treatment, ideally before they get pregnant,
Right.
So, but definitely, once they get pregnant, again, it's a big motivating factor for a lot of people to get sober. And so, it's a good chance to intervene.
have that conversation with them. So often in mortality review cases, you just get a snapshot of the different contributing factors for a death. But based on what you can see in these cases related to mental health, what can care teams do to help prevent maternal mental health crisis and untimely deaths?
Right. So, I think it goes really back to just really increasing the health of our community. So it goes all the way back to preventive health, getting people in for their routine visits to, identify things. But again, without a screening kind of system in place to identify those folks. And I think, continue to kind of increase the number of resources that we have to refer people for treatment. I think normalizing and reducing stigma would have a really huge impact on that.
Absolutely.
So I think, again, just like there's not just one thing that we could do,
Right.
but I think there's a lot of things that would be very impactful in small ways. So, getting our teenagers healthy, preventing even drug use, in the first place, which sometimes, we all went through teenage years. We all know teenagers. Some of us have teenagers, kids are going to do, but trying to create a safe place for them. And then when they need help, that we have the resources to do that. So I think, definitely providing the supports that moms need, that it's okay to take time to kind of seek treatment when we are having, some mental health issues. And so sometimes, especially for small towns, having that under the same roof of the clinic or the hospital, someone who can work with that patient. So, we talk a lot about integrated healthcare. So within their PCP's office, their family practice doctor, that there's somebody there's a very warm handoff to someone in their office. It's someone their doctor trusts. They know where the clinic is. I think that's going to be really crucial to improving all of our mental health care. I think also, just from my experience of having a mental health provider within your practice actually seems to improve the overall culture of
I
the
think
practice.
so.
They do a lot of slide consults.
Yeah.
But, that mental health is not separate from physical health.
Right.
Normalize not being okay.
Yeah.
Right.
Yeah.
Just like, people have trouble with their blood pressure, people struggle with anxiety. And so I think that those are, very important to kind of the whole culture change that we need to have.
I just want to say thank you for coming on today's episode to talk about all of the opportunities somebody has to make such a big difference in someone's life. You've already given us a lot of information, a lot of good information, but I'm wondering, for those listening, is there any other trusted sources of education that you direct people to learn more about what they can do in their practices?
Right. I think there's so many good resources, just even with the CDC, especially because that's where, of course, a lot of this maternal health data is reported, but there's a lot of resources and a great place to start. I think Arkansas is building the resources. The health department is always a really good place to look for resources, especially around other things that you need as far as WIC and SNAP and those sort of things, but definitely around mental health. I think the Arkansas Behavioral Health Integration Network has a growing number of resources for people to refer to. And then, my professional organization, healthychildren.org, is a really good resource. And so I think there's a lot of stuff out there that available on the internet, and kind of looking for those trusted resources and trying to find local resources. And that's where actually, I guess, most people are going to start. I'm feeling depressed, So there are a lot of things that come up, but making sure, you have some good trusted sites. And so sometimes your medical care provider can be helpful. And then again, there's so much going on and so much emerging around maternal health and resources, so much interest. There's often new things.
Yeah.
And so I learn too when people come and ask me about things and can help them kind of walk through that process. So
great. Thank you. Considering over the next 5, 10, 20 years, what resources and supports for mothers and families in Arkansas would be ideal? What do you see that being?
I think we're heading a really good direction in Arkansas and thinking about wraparound services for moms.
Okay.
I think I'm always the person who's like, the picnic, like I want what the ideal picture is going to be. And sometimes I don't like getting bogged down on what we need to do to keep the ice cream cold, and we're going to need napkins to clean things up. Like I need people around me to kind of help do all that.
Yeah.
But I think if we could think about a picture for moms and for our kids is, every child being born to a situation in which mom has the resources she needs. She has a safe place to live. She has, a good source of nutrition. She has, help for what she needs it for, just basic needs, but that also spill over into those mental health needs. And if we really care about women and children, and we care about dads too, if we really care about women and children, it's really kind of, wrapping our arms around and really increasing those supports that help them have healthy pregnancies. Because we know that, just a little bit of investment. I mean, there's just countless studies of where you just provided nutrition services to pregnant mothers and how that improves outcomes and reduces prematurity and has all these other impacts. So really thinking about what we can do in the next year to identify what people's needs are, to create those safe spaces, to provide those resources, and we'll get healthier women, and we'll get healthier children, and we'll get healthier families. And so, I think that people often get upset about what people quote unquote are getting. And I think that when you look at the data and you look at the information, you see the impact that has on these really young families, and what the outcomes can be made better, that it's really pennies on the dollar, So I just would love to see, everybody kind of move towards this. I mean, it's a lot to have a baby, but everybody really surrounding that mother with the support that she needs to be a good mother, and you're going to get healthier children. So, that's my dream.
Again, we want to thank our guest, Dr. Chad Rodgers, for the work he does and his willingness to share his stories and perspectives, as well as a thank you to our listeners for your time today. We hope to see you back for future episodes of the While You Wait podcast. If you're seeking CE credit, please be sure to follow the instructions on the ABIN website and follow or share this episode with colleagues, friends, and family. Until next time, take care.